I now would like to invite Beverly Lazoff, who's going to introduce the speakers to us. So before that, I just want to make a quick announcement. If it's possible for everyone to turn off their videos so that the focus can be on the presenters, and so we can just have more better speaker view. Thank you so much.
Yeah. And so it looks like everyone's muted, except, well, now the speakers are muted as well. But I'm going to spend just a few minutes to introduce our speakers. The focus tonight, as all of you know, which is why you're here, is Santa Clara County Behavioral Health Services. And we have 3 people who will impart knowledge and answer questions for us. We wanted them to discuss how COVID-19 has affected the mental health system and its programs in the county, and how they are working together to improve systems of care. We have Sherri Terao, who is the Interim Director of Santa Clara County Behavioral Health Services Department. We have Todd Landreneau, who is Deputy Director of Managed Care Services for Behavioral Health Services Department. And Curtis Ohashi, who is with Santa Clara Valley Medical Center. He's the Chief Operating Officer for Behavioral Health Services. So I'm going to just tell you a little bit about these people, and then I'm letting them take over. Sherri Terao has worked for Santa Clara County Behavioral Health for about 10 years. She's held roles in Children's System of Care as Division Director and Deputy Director prior to being appointed Interim Director of the department. Before joining Santa Clara County, Sherri worked as Program Director and Chief Program Officer for First 5 Santa Clara County. She has held roles as a clinical provider of mental health services for children and youth in foster care, and has developed and directed prevention and treatment programs in community-based organizations. Dr. Todd Landreneau has been employed by Santa Clara County for about 6 years now, and he has held numerous health and hospital system leadership positions. Over the past 25 years, Todd has held a number of positions in various healthcare settings, both as a clinician and healthcare management consultant. He has also held positions at Stanford Hospital and Clinics, as well as WebMD. Todd received his PhD from Cornell University, and before that, a master's degree in social work from Tulane University in New Orleans. Dr. Curtis Ohashi, who is the new COO at Valley Medical Center. He's brand new. He joined in January, and he comes to Valley Med with over 25 years of executive leadership experience, with a strong operational background in both mental health and substance abuse programs and services. With a PhD in clinical psychology and having served as CEO at various acute psychiatric facilities in both the public and private sectors. With experience in managing inpatient and outpatient services for diverse populations, Dr. Ohashi brings a wealth of knowledge in advancing Valley Medical Center's ability to better serve patients and families. And with that, I will have our 3 presenters take over. Thank you so much for joining us this evening.
Thank you, Beverly.
Yeah, thank you so much, Beverly.
Sure. So are we going to have just them be on the screen, perhaps, and everyone off screen? Can we do that?
If everyone just if you turn off your videos, and I think if you hit on speaker view in the Zoom, then it should actually focus on the person who's speaking. I think pretty much everyone has turned off their cameras. That's great. Thank you.
Okay, great. Well, thank you so much for having us this evening. It's really a pleasure for us to join your meeting. And, I think we, both Todd, Curtis, and I will just maybe say a few words, and then we're happy to open to any dialogue or questions that might be, a top of mind for many of you participating this evening. So thank you for that very warm introduction. We're really pleased to be with you tonight. I wanted to just share a couple of updates, and then Todd, perhaps you can add some of the information that you may want to share as well. But during COVID-19, during the pandemic, the Behavioral Health Services Department has continued to provide services, both through our county operated programming as well as our contract provider services. When we were required to go into shelter in place as a result of the health order, we were tasked pretty quickly with being required to develop policies and procedures for our entire system of care related to social distancing and the use of personal protective equipment, or PPE, in order to support the health and safety of both our patients and clients that we serve, and our consumers, as well as our provider network. We really were tasked also with immediately being able to provide what we refer to as either telephonic or telehealth services. And that suggests that just given the emergency order and the requirements to shelter in place, we had to quickly transition our system to be able to offer services via telephone or via telehealth, which is a video conferencing software that can be used to connect in the same way that we are connecting tonight. So you can see one another over the computer and still be able to provide services. So we were immediately tasked as a system with being able to make those opportunities available to our consumers and clients. We've continued to provide support in the community through our offering of what we refer to as mobile crisis response services. So if someone is having a psychiatric emergency or crisis, they can call our 800 number and someone will speak with them on the phone. And if needed, come out to their home or wherever they are in the community and help to stabilize the situation and provide support. In addition to that, we've continued to offer our suicide and crisis line, as well as our crisis text line. And during the pandemic, and since we've been under the emergency order, we have continued to see an increase in the utilization of both our crisis text and mobile response support lines. We've also continued to provide ongoing support, understanding that many vulnerable populations that we serve, such as those that are unhoused or in need of supports, were able to receive those services. And so the county quickly moved into a position of developing and identifying shelter, motels, and hotels that would be made available immediately for anyone who needed shelter, as well as access to services. And so to date, we have, I think, 13 shelter motels that have been developed in the county to provide those supports. And the services are a partnership between the county, the Office of Supportive Housing, the Valley Homeless and Healthcare Program, and Gardner Healthcare Organization, as well as some of our other nonprofits, have all been moving together in the direction of being able to provide those coordinated services for those that need both shelter and health and mental health support. And finally, we've just continued to collaborate across our multiple systems, and that's why I'm really glad that Curtis is here with us tonight, and Todd, so we can share a little bit more about the ways in which we've been collaborating across our multiple systems to ensure that mental health and behavioral health services are provided. So with that, I'm going to go ahead and turn it over to Todd or Curtis, and maybe you want to just add a few highlights.
Sure, I would be happy to. Can you hear me?
Yes.
I'm going to apologize at the outset. My internet connection is a little bit dicey. I've been kicked off three times. So if I fall into blank space, I'm going to ask Sherri and Todd to fill it in for me. So I started in January of this year, and my responsibilities are BAP and EPS, which is Barbara Harris Pavilion. And if you're familiar with those facilities, those are congregate living. Those facilities, primary strategy to fight the COVID pandemic is to decompress the census. So I worked with first Tony before she retired, and then later Sherri and Todd to look at opportunities where we could decrease our EPS and our BAP census. So one of the first things we did in, I believe this was in April, is we have a number of patients that are waiting for an IMD bed. They're considered subacute. We were able to partner with behavioral health and a variety of other entities to create, for lack of a better term, a 16-bed pop-up IMD. So we're able to move 16 patients from BAP over to this IMD as they wait for a bed. We were also able to develop a 6-bed COVID isolation pod within BAP. Knowing this pandemic would be with us for a long amount of time, it was very likely that we were going to receive patients that both tested positive for COVID and were acute psychiatrically. The primary entities that we follow in terms of the various guidelines that are promulgated for healthcare facilities are the CDC, the state, or the Department of Health, the local public health department, and of course we have the hospital has an infection control. Nobody had the rules pandemic first started, and we kind of picked it up as we went along. So these guidelines are rapidly changing, and our management of the pandemic changed in response. So in addition to the COVID pod and decreasing the census, the other initiatives that we've taken to decrease this, we've set up a telehealth assessment process in the emergency room to assess patients on a 5150 that test COVID positive. We are universal masking both staff and patients for source control. And just last week, we went to universal face shields in BAP and EPS. Valley Medical Center is testing every patient that comes or gets sent over to EPS for assessment. EPS and BAP are likewise testing patients for COVID prior to discharge to other congregate living facilities. We've done baseline testing and retesting of our patient population and our staff. We screen every person that comes into the building, visitors, doctors, patients, vendors, etc., with a no-touch thermometer and a symptom history. And we have also converted our court process to a telehealth process. And then in addition to those, all those other sort of universal recommendations, the masking, the social distancing, the frequent hand hygiene, all of those are in place as well. So with that, I'm just going to end my section and see if Todd has anything to add. And if he doesn't, we'll be happy to answer questions.
Thanks so much, Curtis, and thank you, Sherri. I think both of you did a great job highlighting the work that we've been doing together. I think one thing for tonight that I'd like to highlight for all of you in this virtual community that we're part of is the effort that Curtis just mentioned around patient safety, consumer safety, client safety, and staff safety. So one of the things that we're very cognizant of is that during this time of uncertainty, during this unprecedented time of this pandemic, a lot of people not only are facing stigma around mental health issues, but they're also very fearful about seeking services. And some of that fear stems from the fact that they worry they will either contract the virus themselves or maybe bring the virus home to their family. So in no uncertain terms, the effort that Curtis and Santa Clara Valley Medical Center and Behavioral Health has undertaken to provide a safe environment is really important. We've done a tremendous amount of collaboration to try and stay attuned with the requirements for protective personal equipment, the masking, the social distancing, putting signs in place to let clients who come into our clinics and treatment areas to know that we are doing what's necessary to make the environment safe for them. So I really want to commend Curtis for being a partner with us on that. His experience working in hospital settings has been a tremendous asset to all of us working in the field of mental health. Some of the other things that I'd like to highlight, which I think you might find interesting. So Kyle, I haven't met you before, Kyle, but I'm really intrigued about some of the work that you've already discussed, particularly Facebook. So just a little over a year or so ago, we hired an individual in behavioral health to concentrate on social media. And she's really been a blessing for our department, if you will. She has a presence on Facebook, and she also works with our public affairs officer and keeps our Facebook page fresh and alive with a lot of useful information. Both Sherri and I have been asked on occasion to identify professionals in our department who could do live streaming on Facebook and talk about issues that are related to mental health and also mental health during COVID-19. And those have been very well attended. The questions are really spot on. And we're very grateful to have that platform, as well as Chiaki, our Facebook and social media coordinator, to facilitate that with us. The other thing that's, I think, of interest maybe to this group is from the questions that you posed, you're acutely aware that there may be certain subpopulations that are more at risk for anxiety, depression, isolation during this pandemic. And I'm aware of at least two efforts that I think really speak well in terms of how the county is trying to be thoughtful and mindful to address these vulnerable populations. So one area within behavioral health is our LGBTQ Wellness Center. And our Wellness Center is managed by a senior healthcare program manager, but she actually has several peers that do outreach and engagement with LGBT population. And if any of you are paying attention to the media right now, that is one population that is deemed to be at risk for depression and anxiety during COVID. So her team has been really instrumental at coming up with creative ways to engage using not only social media, but let's see, they call it a drive-by handoff. And so the peers go outside, people drive up in their vehicle, and we have handed out goodie bags with information related to behavioral health, inspirational messages and cards, and have really tried to be creative and thoughtful for our LGBT population and colleagues. The other thing that we've done, which I think is really quite innovative, most of you on this call and this virtual community that we've assembled, the county has an Office of Immigrant Relations. And our coordinator at the Office of Immigrant Relations has worked with us and developed a number of sheets and fact sheets that can be used to talk with immigrants who or may be fearful around coming in for services for a variety of reasons. And they have compiled a very nice library with information on mental health. And so we continue to partner with. We've also partnered, both Sherri and Curtis, with Valley Homeless program. And we have supported them with clinical resources as well as consulting resources on issues to do outreach and engagement with hard to reach populations. So there's many more things that we're doing, but those are some of the creative things that we're doing that I thought you might find interesting to hear about. And then I think the last thing that I'll mention to you, and Curtis touched a little bit on this, we are actively also trying to address capacity needs. So as Curtis said, we had to really brace for really an onslaught of potential backlog of clients and patients just due to the pandemic. And with the social distancing requirements, our older facilities really couldn't accommodate those. So in partnership, we did a lot of thoughtful thinking and planning, and we were able to successfully consolidate some of our services, specifically our central wellness clinic and mental health urgent care, but also some other outpatient clinics. And it's actually worked very well. The staff have bonded with their new colleagues in a very positive way, and they feel very supported. Our community workers, our peers, our rehab counselors are all working and stepping up as needed to do the extra level of support to do outreach and engagement right now. And I'll stop there. I know there were some questions, and as Sherri and Curtis said, we're happy to entertain some of those.
Thank you so much, Sherri, Todd, and Curtis for the update. Yes, we did receive some questions, and I'm going to ask, but also I want to let everybody know that feel free to use the chat to type your questions, and then I can ask them. Or if you want to ask in person, you can raise your hand. I think there is an icon down below. You can raise your hand, and then I can let you, in to ask you the questions. Let's see. We see some questions. I'm going to ask you some of them. So the one question is, what is currently happening with the budget for behavioral health due to the budget challenges for local government? Also, any news on creating more supported facilities to house those living with mental illness? I think you did give some updates about that. Something like Riviera Villa, as well as more inpatient programs with longer stays for stabilization.
Sure, so I can address the budget question. I think most folks know that even prior to COVID-19, the county was already facing a structural budget deficit. And with the addition of the pandemic, it really challenged the county in many ways budgetarily. While we were able to access some of the federal funding as a one-time augmentation for the current fiscal year, which helps offset some of our expenses in the current fiscal year, we are continuing to face a general budget deficit in the county. So with respect to behavioral health services and actually all departments across the county, we're all having to look at different ways of operating that can actually begin to create efficiencies to save funds. However, I will say that with respect to behavioral health, there are huge supports, not only from our Board of Supervisors, but across the county in terms of really thinking about the importance of maintaining as much of our services as we are able to do so. So we're continuing to look at our service delivery network, figure out, to Todd's point, where we can create opportunities for consolidation and cost savings. and at the same time maximize the services that are available both through our county operated and our contract provider network to make sure that we can meet the demands for those that require services and support. So we did have to make some reductions to our county budget. Those came through, if you did listen to the county budget hearings about 2 weeks ago, through some what we refer to as vacant positions. So positions that are unfilled, we were able to put forward as a way to reduce our budget. And we did have to make some minor adjustments to some of our contracts. However, we will continue to work with our community and provider network as we move forward with additional reductions in the near term. But again, we're always looking at ensuring that we can maximize the services that we have in order to meet the demands of those who need access. So with that, I'll ask Todd or Curtis if they wanted to add anything else related to the budget.
The only thing I would add is that my cost center, my budget lives with the hospital, not behavioral health. And as Sherri said, we received federal monies to offset some of our direct and indirect costs related to fighting the pandemic. So as she said, that's a one-time augmentation that will help in the current current fiscal year, but there's a structural deficit, so we need to look at making further reductions. And the hospital is focused primarily on areas. These are things you may or may not be aware of, but these are kind of the usual suspects when you're looking at a budget cut in the hospital. But it's primarily services and supplies, increasing labor, and then looking at, I think there was like Sherri also mentioned, there was a number, and I don't know the number, but there are a number of unfilled funded positions that you could just kind of unfund and give away without having any detrimental effect to services. And some of the positions, the unfilled positions in the hospital have been unfilled for quite some time. And so that's what we primarily had focused on for balancing the budget in the hospital.
Yeah, and I think I would like to add, I know Sherri also touched on this, but we are, even though the county and our department is having to be very measured in cost right now, being careful with cost, we want to assure you, you have our full commitment that we are looking very carefully at services that are driven by need, and those services that have strong need and impact in the community, we're going to do our best to preserve and enhance those. So I actually, hi Vic, I didn't get a chance to say hello to you earlier, but I want to thank you for your question. You're asking about suicide and prevention program. That's obviously a very important program in behavioral health. You definitely have Sherri and I's commitment. We know our suicide and prevention program has actually won awards, and we are very proud of it. One thing that we can share with all of you is that the crisis text line has received a higher than usual volume of calls during the pandemic. So we continue to monitor the crisis text line as well as the crisis line. And our manager, Lon Nguyen, who you all know, is working with us closely. He provides us with metrics, I believe, on a weekly basis. And so you do have our commitment to continue to support that program. And any way we can strengthen it, we will definitely do that. There's another question related somewhat to budget and services from Harold. And Harold, I wanted to respond to you. Your question is, how are we able to help patients who may not have adequate bandwidth to connect remotely? And this particular question is also related to Sherri and I's commitment and Curtis's as well, to focus on where there is need. So early on, the Department of Healthcare Services asked our department to identify what is essential services. And that exercise required us to look at which driving demand, what are the types of services that we envision are going to continue to need to be sustained during this pandemic, no matter what. And obviously that's outpatient services. So without a doubt, who may not be able to connect remotely with us using telehealth, they still have an option to come in and see a clinician face-to-face at a variety of clinics, both on the children, youth, and family side, as well as on the adult side. So we do have that commitment. Our staff are very interested in not taking that tool out of their toolbox. They like and see the benefit of seeing clients face-to-face. And as long as we can provide the PPE to both our staff and the clients, they are committed to providing that service.
Thank you. Thank you, Todd, Curtis, and Sherri. I too have another question. How can one get more engaged in connecting with the community to help educate the immigrant population on mental health?
Yeah, that's a good question. I've actually been asked that before, and as I said, it's we do have a really robust Office of Immigrant Relations, and they do have some outreach phone numbers and email addresses. I can provide that to you after tonight's meeting, Rovina, and you could distribute that. But there are opportunities for people to get involved. We also have volunteer opportunities in behavioral health as well. So those are two options that I could provide information on.
Definitely. Thank you. Thank you so much. The other question is, after COVID-19, how will it have impacted the future of behavioral health services?
We should all comment on that. Curtis, do you want to start first on that one?
Yeah, I'll be happy to start off. So I think for us on the hospital side right now, it's all about being able to provide access to patients, both behavioral health and non-behavioral health patients. When the pandemic started, we had zero infrastructure for telehealth visits. And so we had to build that capacity. It's more of an outpatient service. Obviously, if you're in the hospital, that requires, face-to-face care. But what we've been trying to do with our clinic system is to push both video visits and telephonic visits when they're appropriate. All of the oversight agencies that govern those service lines have relaxed their standards to allow healthcare facilities to provide those services and obtain reimbursement and sort of cut out a lot of the red tape. And so I think that at some level, while the pandemic's going on, any business or any healthcare facility is going to be limited by capacity issues. So if we're socially distancing and we're used to having a waiting room that once was full of patients, now there's only a certain number that can occupy that space. And so to provide access, at least at the hospital side, one of our key strategies has been really to push telehealth, video visits, and telephonic visits when they're appropriate.
Yeah, I would echo that. I think one of the pieces of the system that we will continue to sustain beyond the pandemic will be telehealth. There's so much that we've learned about implementation of telehealth, and for many patients who actually have engaged with us in that way, we've learned a lot from their experience. So I do think that's something that will continue. I think the other thing that we've learned quite a lot from is we've done quite a few town halls. So beginning in March through the current time, we've conducted many town hall outreach sessions. One, to reach out to underserved and unserved communities that we may not have had contact with prior to the pandemic. And many individuals from different cultural groups and communities had been reaching out to our department to learn more about how they could access information on COVID, how they could access information on mental health. And quite honestly, the opportunity through technology and Zoom has really been able to create opportunities for us to reach out to so many more individuals than we had even prior, when we would do more in-person community meetings or town halls. So we're gathering all of the information that we've learned from those town halls and really trying to develop and adjust our service delivery system in ways that we think can be more helpful. One being our website. We've done quite a lot of adjustment to our website to be able to provide additional information. Some of our peers and consumers and our staff have developed videos that are now available on the website to explain what mental illness is, how to access services, how to call our call center, how to access crisis services. So for many folks that have kind of checked out our website more recently, we have a lot of additional information that we think can be helpful. As Todd mentioned, we're still continuing to provide both in-person and telehealth because for other individuals, there is a preference to still be able to come in and have your face-to-face therapy session or counseling or case management opportunity with a clinician or peer. And so we're, I think even, after the shelter-in-place order is lifted, we'll still provide a mix of opportunities to access services. Todd, did you want to add anything to that?
Yeah, thank you, Sherri and Curtis. I think what I'd like to add is also just fundamentally how we are operating as a department and maybe a health system overall. I'll keep my comments limited to behavioral health, but it's actually quite intriguing to me what we've done over the past couple of months, and hopefully you would see the value of this. So as part of the pandemic, as terrible as it is and as stressful as it has become, it's also given an opportunity for Sherri, myself, and other members of the executive team, both in behavioral health, but also within the health and hospital system, to communicate in a much more regular way with our staff, including clinicians. So specifically what I mean, previously we would often be able to host a monthly meeting with our behavioral health staff, which is just under 800 or so employees. Now we are able to host that meeting monthly with a fairly dramatic increase in participation. The engagement by the entire department is so dramatically different than it was when it was face-to-face for a variety of reasons. But number one, we seldom had a venue large enough to accommodate that many people. But because now with remote technology, we're able to host these forums and also take questions, just like we're taking questions from you this evening, and respond to every single question from our staff. And so that's actually had a very positive impact, in my opinion, because they see leadership being responsible, accountable to ideas that they put forth to us, responsive to needs around self-care and ideas on how to make their work environment more supportive. And so in that respect, it's changed the demeanor and tenor of the entire department and how we relate with one another in a very positive way, I think.
That's some benefits of internet, right? And doing everything remotely.
Yeah.
Yeah, thank you. Thank you for answering the question. The other question I have is, when will a new children's, adolescents, adults, acute psychiatric facility open in Santa Clara County?
That's scheduled to open October of 2023, and I was actually teed up to give an update on the status of that building in your October general meeting.
Okay, all right, that's great. Then I have some questions in the chat. Let me go over them. How have patients, clients been doing during the last 5 months in caseload increasing, decreasing, contacts increasing, decreasing? Are we losing track of people? Any differences from general population relative to COVID?
So I'll just make a quick comment, and then Todd, maybe you can fill in a little bit more. So when we immediately went into shelter in place in early March, we did at that time see a decrease in the number of individuals calling into the call center. So we had clients and patients and consumers that we were currently serving that we reached out to immediately contact to let them know how we would continue services. But initially, when we had the emergency order, we did see a dip in calls to our call center, and that was probably for the first maybe 4 to 6 weeks. You know, understandably, everyone had gone shelter in place, and we kind of had to quickly shift in that way. At present, we're currently back to our regular demand for service, particularly in the adult system of care. I will say in the children's system of care that we are seeing fewer numbers of parents and youth call into our call center for services. However, we have many contract providers that were connected to school-based services, and our schooling services, which are services available in 13 school districts throughout the county, for which we have what we call schooling services coordinators that stay in contact with the school and the teachers and the families to be able to link youth to services. So we're continuing to strategize to ensure that, and I'm going to focus a little bit more on the children's system here, that children and youth and families that need support can still access those. And so we've done quite a lot of outreach through Facebook Live and through other social media opportunities, just to ensure that parents who may be struggling or whose children may be struggling are aware of the ways in which they can continue to access services and support. So with respect to current demand for service, we are pretty much back to where we were prior to the pandemic starting. And we're continuing, at least on the children's side, to do additional outreach and supports to make sure that children, youth, and families have access to those services.
That's great. Thank you.
Yeah, and I think maybe I'll just add two more pieces here. We have hired a relatively new division director for Consumer and Family Affairs, Mikkel Lee, and I think a number of people on tonight's community call are familiar with Mikkel's work. From mobile crisis and other areas. She's been in our department for quite a while. So Mikkel is doing a bit of brainstorming with both Sherri and myself, and we've been talking about how to more creatively use some of our peer support workers. She's had a number of conversations, at least in the last 2 weeks, from my conversation with her, about how to use the peers in this particular area. We have peers in other parts of our healthcare delivery system, but within consumer affairs, how we can use them to engage with clients who may be a little bit hesitant to call their clinician. And so I would say stay tuned. I'm very excited about some of the ideas Mikkel has been talking about. For those of you who aren't aware, we're also in the midst of launching a new electronic health record. It went live last week. And so Mikkel and I have been having conversations about how to use that electronic health record to help with some of these outreach activities. So I'm expecting good things to happen real soon in that way. I think just to go to, I believe it was David who asked the question about differences in the general population related to COVID. So Sherri did highlight, I think what we're noticing internally in our system of care, both between children, youth, and family and the adult system, the adult system does look like it's back to pre-COVID levels. But what I have found to be very interesting, and it might be interesting to some of you because it's statistics that drill down to different age cohorts, but also gender and race and ethnicity. So the Center for Disease Control, right after the pandemic started, implemented a survey. I believe they were using portions of the PHQ-9, which is a depression, as well as the GAD, which is a anxiety disorder inventory. And anyhow, they took the best of both of those surveys, and they started implementing a questionnaire that was asked across the United States to many different populations about how COVID is impacting their families, and what's the anxiety rate, the depression rate, is there an impact? And as you might expect, generally speaking, I would encourage you to check it out. It's on the CDC's website. But just under 40% are reporting that the pandemic has had an impact on their anxiety or depression levels, which is high. It's not 50%, but 40% is high. And then also, surprisingly to me, as a former gerontologist, it appears the 18 to 49-year-olds are struggling more with the results from the pandemic than those who are older than 49. So again, I find that very interesting. You could feel free to check it out at the CDC. I have some theories why that is, but there's a lot of interesting reading on this, and we continue to watch this information and try to adjust our programs internally and our outreach efforts accordingly based on this information.
That's very interesting. I think that's definitely going to be something that I would like to read and know more about, because the impact of COVID is on everyone. So thank you for sharing that resource.
Sure.
I have a question from Uday. Any update on the Office of Supportive Housing, as Kylie has taken a new role?
I can just give a little bit of background. So Keely was a former director of Office of Supportive Housing, and he was recently promoted into a deputy county executive role in the county, which is really fantastic. He's an amazing leader and has led for many years in the area of housing and supporting services and projects to help unhoused individuals in the community. Currently, Consuelo Hernandez, who was the deputy in Office of Supportive Housing, is currently in an acting director role. So Key and Consuelo continue to work together actively to ensure that all of the supports around Office of Supportive Housing are continuing. And as Todd mentioned earlier, within behavioral health, we have a supportive housing services division where we are very interconnected with the Office of Supportive Housing to ensure that for those individuals that are receiving mental health or substance use treatment that do need permanent supportive housing or other housing options, that we are making those linkages and ensuring that those services are available for those that we're serving.
Thank you, Sherri. Any other questions that anyone may have? You can either raise your hand or just type in the chat box. I guess not. So thank you so much, Sherri, Todd, and Curtis, for joining us tonight and giving us all these updates and all this information and resources. I think this has been really helpful. And I think we do have a question. Carol.
Yes, thank you. I work with the NAMI Jail Court Support Group for Families, and I was wondering what our vulnerable population from the jails, how that's being addressed. What we're hearing a lot from families is that people are released, everybody's moving people through quickly as possible to get out of these COVID situations where they're incarcerated, there's high populations, people are being released to a homeless shelter and end up on the street. And what is being done to address the problem with incarcerated individuals and their follow-up treatment? Thank you.
Well, I think I could provide a little bit of context around that answer. I can't comment on what the COVID management practices are in the jail, but I do know that they are engaging a similar strategy of what we're doing in BAP and EPS, or trying to decrease their overall census so they can social distance and they have opportunities for self-quarantine. So that being said, what I can say is the number of patients that EPS receives from custody health or the behavioral health services in jail has gone up dramatically in the last 6 to 8 weeks. So I can't comment if they're actually releasing them to the streets, but typically the practice is they get sent to EPS, and then EPS will create a discharge/placement plan for them.
Thank you. I do see some other questions here. So let's see. How does one get into supportive housing? They're literally throwing people out of jail with any resources. I think they meant without.
And again, I could comment on one piece of that answer. So the Office of Supportive Housing has secured, I believe now it's 2 motels or 2 hotels that have been vacant during the pandemic. And that's where they're housing folks that are mildly symptomatic, that have tested positive for COVID, that don't have any other housing alternatives. And some of those patients are the patients that Todd referenced. So for example, if we get a COVID patient in EPS, but they don't need acute psychiatric services and they need placement, we've been able to utilize, for lack of a better term, we've been calling it the COVID hotel, but I'm sure it has a name, but that's what the purpose is. And I know that's one avenue to secure temporary housing.
Okay. The other question is, are you able to place everyone who arrives at the BAP after jail? What kind of placement is available?
That's a complicated question. So the placement options run along a continuum of care. And so at the highest, most restrictive level, you have a facility like a state hospital. And at the lower end, you would have facilities like shelter beds or board and cares and so forth and so on. I know EPS's biggest challenge is not obtaining placements necessarily for patients, it's getting the patients to comply with it. And so typically with these facilities, there's rules of what the clients or patients can and can't do. And quite often, it's not an unusual occurrence that we will provide a referral for housing in EPS, but the patients will simply not agree to comply with following up with it.
Thank you for answering. Any other questions? Okay, I do see. I don't know if it's a question. Families with an adult living with mental illness cannot access the grievance system. Sometimes difficult situations are brought to NAMI's attention. Is there a designated person in the department that can be of contact?
Yeah, let me take that question. So within the quality management area, we do have a team of individuals that can take beneficiary complaints or grievances. So you could call the main number to the department and let them know that you have a complaint or a grievance, and they would route you to the appropriate person.
And then I do see a comment. It's not a question. It's basically one of our participants' loved one got a bill since left the hospital before they wouldn't do it before, and was completely unexpected. To give more information, went to crisis residential when needed more hospital time, had paid rent already, and then got housing services bill from crisis residential that I didn't know was signed by a loved one who had no other place to get help. So they just want to let you know about the issues because of COVID changes. And then another comment is families cannot access the grievance system, only the consumer.
That's correct.
Yeah. All right. Any other questions or comments? Let's see if anyone has their hand raised. All right. Looks like we don't. So thank you, Sherri, Todd, and Curtis. Thank you so much for coming tonight. We do have one last question, but I can also send that out as an email to you, and then you can respond to it, and then I can send it out everyone with the recording for this meeting, if that is okay. So thank you once again. Thank you for the resources and the updates and all the information that you provided us today. This was very, very helpful. We really enjoyed ourselves, and I hope to see you again in person sometime soon.
Likewise.
Thank you, everyone.
I'll be there
else
next
for
month,
attending.
so virtually.
Yeah.
Thanks, everyone.
We really
Have a
appreciate
nice
it.
evening.
Thank you.
Bye-bye.
Thank you.
Bye.